Hey fellow nurses, welcome back to my channel where we make nursing knowledge fun and accessible. And today we are kicking off our brand new medication series. This series is going to be super helpful for your continued education and NCLEX preparation or just general learning purposes. Whether you are a student prepping for exams or a new grad getting oriented or a seasoned pro looking for a refresh. Plus, it's a great way for me to revise and stay sharp too. We will break up key medications in an easy to digest way, starting with one of the essentials, penicillins. So first up, the penicillin class overview. Penicillin are like the superheroes for antibiotics. They have been around since the 1940s, discovered by Alexander Fleming, and they are still first line for tons of bacterial infections. Why? Because they are effective, relatively safe, and cover a bunch of common bugs. As nurses, understanding penicillin is key because they are used everywhere, from community clinics to ICUs. They help fight infection by targeting bacteria specifically without harming our human cells. But remember, they are not for viruses like flu or COVID. That's a common patient misconception we will touch on later. Key point: penicillin are bactericidal, meaning they kill bacteria outright, not just slow them down. Their spectrum, mostly gram-positive bacteria like strep and staph, but some extended hit gram-negative too. We will break that down more. For safe admin, always think about the patient's history, lab results, and how the drug interacts. This class sets the foundation for optimal outcomes like fewer complications, faster recovery. Now let's talk about medication mechanism of action. How do these bad boys works? Imagine bacteria have a tough outer wall like a fortress made of peptidoglycan. That's a fancy word for a sugar protein mash that keep the keep the bacteria intact. Penicillins swoop in and inhibit or block the enzymes that build that wall. So it break that wall technically. Specifically, they bind to penicillin-binding proteins and stop cross-linking in the peptidoglycan layer. Without stronger wall, the bacteria cannot handle internal pressure and they burst and die. Easy analogy for you. Think of it like building a brick wall without mortar. The bricks, the sugars, fall apart. This makes penicillin most effective against effective growing bacteria, which is why timing doses right matters. For nursing students in NCLEX questions, remember penicillins are time dependent killers. Consistent blood levels are crucial, so don't miss doses. Moving on to common drugs in this class. Not all penicillins are same. They come in natural and semi-synthetic forms. Starting with OGs, which is penicillin G. That's the IV or IM version. Great for serious stuff because it gets into the bloodstream fast. Then penicillin V, which is in oral form, easier for outpatients. Broad spectrum ones, amoxicillin, super common, often with where we have to fight resistant bugs. Ampicillin, similar but hits more gram negatives, used via IV or oral. Others you might see like Zocin for hospital infections. Know these names. They will pop up in med orders. So, pro tip, amoxicillin is kid friendly, tastes like bubblegum in liquid form, but always check routines and routes. Some are IV only to avoid GI upset. Okay, primary indications, where do we use these? Penicillins are go-tos for streptococcal infections like strep throat or scarlet fever. Think group A strep, right? Skin and soft tissue infections such as cellulitis from staph, sorry, pneumonia, especially community acquired from pneumococcus, otitis media, ear infection in kids, amoxicillin um, is first line. Syphilis, penicillin G is gold standard even for pregnant patients. Also, endocarditis prophylaxis before dental work for high risk hearts. Real world example, a patient with the dog bite. Ampicillin might cover the mix of bugs, but always base it on cultures. So don't guess. Next tip for NCLEX is, if a question asks for first line for beta hemolytic strep, penicillins, your answer. And remember, they are useless for MRSA. That's vancomycin territory. Okay. All right. Critical nursing considerations. This is where we shine as nurses. Always safety first. Number one, always screen for allergies. Penicillin cross-react in about 2 to 10% of cases. Ask, have you had a rash, hives, or breathing issues with antibiotics? If yes, dig deeper. Was it true anaphylaxis or just nausea? I know some people have some reaction with medication. We cannot say that they have allergies, so we have to know more about what kind of reaction they had, right? Monitor for anaphylaxis like rashes, wheezing, hypotension, swelling. Always have your epi ready. That's why we observe after first dose. We want to know what kind of reaction they are having, right? Obtain cultures before starting. Know the bug to target it right. Assess renal function. Penicillins are excreted by kidneys, so those are just in chronic kidney disorder. So people who are not able to tolerate, we have to adjust the doses even though they are adults, and we have some criteria of medications for adults, but in some cases we have to adjust those doses, so we have to check with our doctors and educate patients. Finish the full course even if feeling better, prevents resistance. Take with food if GI upset, but not with dairy for some, right? Watch for super infections. Killing good bacteria can let yeast or C. diff take over. Signs would be thirst, diarrhea. If you see these kind of signs, report ASAP. Other tips would be IV pushes slow to avoid vein irritation. These medications are very irritating when you push through IV. For peds, calculate dose by weight accurately. Common side effects. What to expect in teach. GI upset tops the list. Nausea, vomiting, diarrhea, probiotic yogurt usually help in these kind of conditions. Skin rash could be allergy, so stop and call doctor. Fever, sometimes a drug fever resolves when we stop the medication, and sometimes it's very common for some people. Anaphylaxis, rare but life threatening. throat closing, BP drop, those are the emergency conditions because it's related to respiration, right? And also cardiac function and perfusion. So we those are the emergent situations. Less common, neutropenia in long courses or seizure in high doses with poor kidneys. So that's why we have to adjust doses. For patient education, if you get severe diarrhea, like if we need to tell them if you get severe diarrhea, it might be C. diff, so we need to check it. Normalize mild side effects, but stress reporting serious ones. Sometimes people feel mild rash, or sometimes their BP drop, but it's not very serious, then could be really mild effect of the medication. But as I mentioned before, if they are not able to breathe, they are really having hard time, their BP suddenly drop, um, we need to let doctor know about it, right? Finally, our safety alert: about 10% of the people report penicillin allergy, but true IgE medicated ones, the scary kind, are only 1 to 2%. Many allergies are actually intolerance or viral rashes, um, mislabeled. Always verify what was the reaction and when it was. This prevents unnecessary avoidance. We have allergy testing for that as well. So when patients say, "Oh, I don't remember, I had a rash when I was a kid, but I don't completely remember what it was," so it's better to check it before you start the penicillin dose. A big deal for nurses is over labeling means using broader antibiotics, breeding resistance. So challenge histories politely. So always double check the histories, always go and check their charts, read their chart and see if they have ever had that kind of allergies or something else. For example, a kid had a rash with Emox during the virus, probably not true allergy. So consult allergy specialist if needed. So always double check. That's our deep dive into penicillins. If this helped, like, subscribe, and comment your biggest takeaway. Maybe a penicillin story from clinicals that would be really interesting. Check the description for resources like lexicon links. Next up in our antibiotic series, we will go through all the common penicillin drugs and how it works. So come back for that and we will discuss more about it. Okay, thank you so much. Have a good day.